My name is Kinga Sigeti. I'm a neurologist and I work at the Jacobs School of Medicine and Biomedical Sciences. I'm a professor and I'm the founding director of the Alzheimer's Disease and Memory Disorders Center, which is our clinic with UBMD Neurology. We see all kinds of neurodegenerative diseases. We also got the designation of Center of Excellence for Alzheimer's Disease from the New York State Department of Health. So we developed a multidisciplinary clinic that is standard of care around the country. We have a multidisciplinary team and patients are seen in 3 consecutive steps. The first step is when patients are referred to come in for a new patient visit. At that time, we take a thorough history, look for signs and symptoms of cognitive impairment, do some screening tests. We do a full physical and neuro exam and develop a differential diagnosis. At that point, we typically order a set of 3 tests. The first is blood work for correctable causes and modifiable risk factors. Then we get neuroimaging. Usually it's an MRI of the brain because everybody deserves a scan before they get diagnosed with dementia. And finally, in people who are doing really well, they're very mildly affected, we need to put them in the context of the age group. So we rely on our neuropsychology colleagues. They do a formal neuropsychological evaluation, which takes about 2 hours. They test the brain, how certain parts work together to do a certain function. After this, tests are performed. We have a consensus meeting with our multidisciplinary team where we discuss every single patient. We put together, what the diagnosis is, what's the best treatment approach. We have our social workers to develop a care plan. And after this consensus meeting, people come back for an appointment. We call it the first follow-up appointment. That's when we give the diagnosis, counseling, what to expect, describe and recommend both pharmacological and non-pharmacological interventions such as lifestyle, diet, physical mental exercise, hearing and sleep. All of these are very important risk factors for Alzheimer's disease. Our multidisciplinary team has everybody who has some interaction with our patients. So it's the providers, we have the social workers, we have our neuropsychology team. We have 3 neuropsychologists working with us. Frequently we have a psychiatry representation, and then we have nurses, clinical trial coordinator to really look at every aspect of that patient and what can we offer. It varies by the time of the year and how things are looking, but usually we can get somebody in within 3 months. That's our goal. Really, we would like to work with the primary care doctors. Please, talk to us, call us. It's a little bit of time investment on the front end, but we can develop strategies and workflows that minimally adds to your workload but helps your patients a lot, and you can screen out who you can take care of. We provide consensus conference participation for primary care doctors. You can bring your patient and describe, do a presentation, a brief presentation. We can give you advice how to proceed, what medications to use, what workup would be beneficial. And then again, the cross-referral pattern, if you are comfortable of taking care of your patient, you just need a diagnosis and initial treatment plan, we can provide that as well as a consultation, and you can take your patient back. So we are open to any kind of collaboration that will help patients and provide care for everybody who needs it. There are people who really benefit from these monoclonal antibody treatments. These are not cure, but it does delay progression by about 30% over 18 months. And when we look at it from a little bit different angle, that means that people, the much higher number of people on the drug remain in amnestic mild cognitive impairment and do not convert to Alzheimer's, or they remain in mild Alzheimer's if that's how they started and do not move to moderate stage Alzheimer's. That buys time, about a year of extra time, when you are more independent, when you are not relying on your family. It is scary when you just read about it. When you hear about the potential side effects, bleeding and swelling of the brain, it sounds scary, but after doing it for some time, and we were actually part of the clinical trial as well for Kisunla, it is really a managed risk. So we know that it can happen, but we prevent it. One very important thing that you see sometimes in the news, that somebody died of a bleed. A couple of those articles were actually specifically for people who got blood thinner for a stroke. We call it thrombolysis or clot buster. And because your vessels are a bit weaker, if you are going to give a clot buster, that people can bleed. So now we know that people who are on this medicine should not be treated with those clot busters. So we can really manage this risk. So anybody who has amyloid on the brain, which is the bad protein that accumulates in Alzheimer's, for that you need a special test called amyloid PET scan. And we usually order that for people who look like, by their symptoms and signs, that they have Alzheimer's. There are certain things that make you not eligible or higher risk. And these are, if you had a stroke, you should not get it. If you have any blood on your brain, if you are on anticoagulation, let's say you have AFib, and then you are on either Xarelto or Eliquis, because of the increased risk of a larger bleed, we don't give it. And that's about it. There's a genetic risk factor for increased side effects called the ApoE4 genotype. Then you are at higher risk, up to 20% risk for side effects. Actually, I brought clinical trials to Buffalo because people were asking in the clinic, is there anything else that you can do for me besides the medicines that we already have? And we started working with different industry companies to develop drugs. So the clinical trials are about these monoclonal antibody treatments. The first one approved was Leqembi, and the second one was Kisunla. They have very similar efficacy. Both of them clear the amyloid and the slow progression. The question is it going to separate the treated versus non-treated even more? Would it really completely stop the disease after a while? These are questions for the future. And it's very reassuring that actually one that we developed, Kisunla, has turned out to be efficacious. So this is an educational session called Brain Train, and it has basically 3 sections. In the first section, we talk about healthy brain aging. What can you do for yourself to remain cognitively healthy? The second part, we talk about dementia, what it is, what types of dementias are there, what kind of treatments are available. And in the third part, we usually talk a little bit about research. What are clinical trials, how you can participate, what does it really mean, what are the risks and benefits. As part of the Center of Excellence for Alzheimer's Disease, we have the mandate to train every level of the healthcare profession.